I'm going to introduce each of our speakers and then we're just going to get kicked off. So Judy Krasna is the executive director of Feast. I am so excited to have Judy here. She's been in the field for years and has been doing work all over the world. She's going to be sharing her insights from that work, but also her personal journey with her daughter. A mother and has lived experience of these issues. Petra is the co-founder of Hungry Hearts, and as I said, was really the catalyst for this conversation. She's going to be sharing a bit about her journey supporting her daughter through severe anorexia and the importance of compassionate, non-judgmental support for families. And then Sarah is here with us from Eating Disorder Care Support New Zealand, and she will be sharing some of the systemic challenges that families face and also speaking from her own lived experience of an eating disorder and as a parent. And the last thing I want to say before I kick us off into this question is I was reflecting about this conversation before we started, and I was reflecting on my own parents in my own battle of an eating disorder. And I was thinking about how often they were quietly sitting by the bedside when no one else was there, how often they were fighting for me in my own struggles, and how much I battled them, my parents. And often they are the ones that are thanked the least. I've fortunately come out of my experience and can have lots of conversations with my mom and go, oh my God, was I crazy back then or what? Thank you so much for sticking by me. But I want to just say thank you to you, Judy, Sarah, and Petra for that thankless work that you have done, and also for strikes me that you have turned those really difficult experiences into something of benefit for others. And that is a really, I would say, a sacred kind of work, not just going through those difficult experiences, but using them to help other families. So thank you for that. And on that note, I want to ask our first question, which is, what brought you to this work? So how, and you can share a bit about your personal experiences, your professional experiences, but what got you into the work of supporting families?
I'll start. When my daughter was 14, she developed an eating disorder. And we live in Israel, and there are very, very few resources. So I went online and I was searching for information about treatment. I mean, we were willing to travel anywhere in the world just to, get her treated at that point. And I came upon this parent forum by this organization called Feast. It was called Around the Dinner Table, and there were parents from all over the world. And you could ask any kind of question, really anything, and parents will just jump in and give you the most considered and wise and compassionate answers. I kind of got into Feast and the parent eating disorder world then. And eventually when my daughter stabilized, I then kind of turned around and became someone who gave support to other parents. Because I really feel like, along this journey, we collect so much information and wisdom and insight and perspective. And, we should be sharing that with other parents who are coming up behind us so that we can help them really to avoid a lot of the pitfalls that we fell into as parents, and to make their journey easier and shorter and to give their children a better chance of recovery. I got into it that way. I've been a parent advocate, and I guess I would call a parent peer support person, probably about 15 years. Now I became the executive director 3 years ago of Feast, which was actually shortly after my daughter passed away from suicide and anorexia. So I've decided very consciously to stay in this field, because I think that I can do a lot of good and help a lot of people. I know it's difficult because I represent every parent's worst nightmare. Every parent's worst nightmare happened to us. But I think it has taught me a lot about how to help other people. And that's why I'm here. And this topic in particular is very personal to me, really because my daughter had what I would consider a long-standing eating disorder. It wasn't what I would call severe per se, because there were times during that disorder where she was actually pretty okay. but it was longstanding. And there were times when she probably could have qualified, not age-wise, and actually not health-wise, but she would have said herself, I would like to check out, I'm done. And, as a parent, I don't know how you deal with that. Meaning I dealt with her suicide. It's not the same thing as dealing with actually assisting your child to die. And I have a lot to say, which I will say more as we get into the questions about this topic. So I just want to say thank you very much for inviting me here today. I'm really honored to be here with Sarah and Petra.
Thank you so much, Judy. And I'm so grateful that you are in this work and bringing all of that to this work. And thank you for all you've done for the field. Sarah or Petra?
I think Petra's been very lovely and allowing me to go forward, so I will do, or being very modest, I should say. Yes, I really came to this field following on from Judy. My youngest daughter became very ill with anorexia nervosa, age 10. That led me to looking for support. I was told, learn everything you can. And what I learned was there was very little out there. This was 10 years ago, so there was very little available in the way of resources. And I also found my way to online support groups and around the dinner table, which was a lifeline for me connecting with other parents and carers and to other international support groups. I also came from my own lived experience, and that's something that is a very new journey for me to share. And I've only recently been sharing about that because we have really had instilled into us, we do not talk about our own personal issues. We do not talk about our own mental health in an age group that I'm certainly in. I'm 2 years away from 60. And so it's been quite a sort of challenge in sharing that story too. I think it's really important, though, that we also acknowledge those journeys and share these stories, because it also gives hope to others that it is possible to work your way along this path and to really get through this journey and reach full recovery. Our organisation, EDCS, Eating Disorders Care Support New Zealand, I'm co-founder of that, and that was formed about 7-8 years ago by 3 of us parents who all met on international parent support groups. And we wanted to really replicate and give to parents the gift of having that connection in a more local environment, so specific to New Zealand. What we had all found independently was, I think Judy actually said when we spoke before, you could literally jump online and have somebody reply to you instantaneously because somebody was always awake somewhere in the world. And we wanted to have that same level of support available in New Zealand. We also wanted to be able to share our hard-won resources of health pathways and how we could access localized support and make that journey a lot quicker so parents were able to support their children much more quickly. Bless you. So really that's how we came about. So fast track to 2 years ago, EDCS became a full charitable trust. We offer online support group to a private online support group to carers and parents of people with eating disorders. We call them children still, no matter what age. Probably our oldest child that is connected to the group, the parents connected to the group, is 49 currently. So it's really affects all ages. We also have monthly meetings, we have subcommittees, and we do an awful lot of advocacy as well as providing resources and support for carers. So we really are firm believers in system changes and recording how well things are working. And so this is another part of the area that we're working in. But this particular area is a really deeply personal area for me also. I came close to losing my own life through my own journey when I was around 14, 15 years old. And I recognize a lot of that has been completely blanked for me. I really understand how much it affects your thinking and how much I really appreciated having my parents around, being there for me, offering that support. And we're still working through a journey with my own daughter. So she is what we would call long-standing with an eating disorder, largely because we've been unable to access the really individualized and supportive treatment that she needs. So that's really our journey to date. She came close to losing her life too. And I just really do not want to see other families going through this. So it's a particular area of interest and passion for me to try and share our story and to assist where we can for other families.
Thank you so much, Sarah. Petra?
Okay. Yeah, thank you so much, Sarah, and also Judy. You just express your intentions, your energies. They are really so similar to mine. So I just focus on our history with our daughter. Just give a short telling. Yeah, looking back, I can say that our daughter's illness began during her puberty. As a family, we didn't attach much importance to it because we all so busy with school, with our work and our sport. Our children are very active in sport and we often accompany our children. And there was so little time for in-depth conversations. And when our daughter finished school, she went to another city to study. And the organization of her studies, the organization of own living, and the demands of her sport were too much for her. After a year, I brought her home, partly because her friend drastically described the changes in our daughter, especially in her eating habits. At first, our daughter asked for medical advice herself, but that didn't help. I then called a psychologue. It's very difficult for me because I'm a little nervous to speak it in English, and who advised her to register in a clinic immediately. It took 3 months and for her to get a place, and the illness was already very advanced. So I looked for help on the internet because the doctors either seemed overwhelmed or trivialized our daughter's condition with statements such as, she just needs to eat, then the problem would no longer exist. Sometimes I also had the feeling that they were trying to blame me for the messed up situation. In the end, our daughter was in 3 clinics and slipped deeper and deeper. She had to leave the last clinic because they found laxatives in her luggage. She was discharged with a BMI of 11.1. And in Germany, you have no right to outpatient therapy with a BMI which is under 14. So we searched and searched again, and in the end, she died in a hospital 3 months after being discharged from the last clinic, the clinic who had to help her. Today, 4 years she had passed, and I worked through a lot of things, also with her diaries and also with all the letters she wrote to me. Sorry. I had to stop for a moment.
It's okay. Yeah, take all the time you need. Yeah, Petra, I'm so grateful that you're sharing your story, and we went back and forth by email, and I think I told you the first day that I got your email, and my heart felt like it went into my throat. Um, just just deep, deep sadness. At what you experienced. And I remember also feeling it was so unfair. And so there's so many emotions there. And I can only imagine all of that as a family, holding all of that. Um, you tell me if you want to continue. I can ask another question, or I'm completely up to you. Would you like me to ask a question, or do you want to?
I just want to continue.
Yeah,
Sorry for that,
continue.
but
No, you
yeah,
do not need to apologize, my
yeah.
friend.
I was always looking for people who would have listened to me, who wouldn't have judged me, who would have shown me perspectives, who would have known alternative ways, who would have simply accepted my despair and my anger. The involvement and support for family members is a cornerstone of the recovery process. It needs understanding, acceptance, and non-judgmental space. And this is what we are working for with our association, the Hungry Hearts.
It's beautiful. It's beautiful. Thank you, Petra. And it's that I don't know what else to call it, but sacred work. You can call it service, you can call it whatever you like, but really no better human being than you to be doing this work and supporting other families. So thank you for that. Um, I really want to just get straight to the heart of this. I shared with you all when we had our pre-panel that uh, I've had a lot of conversations with different organizations in the eating disorder space and in the suicide prevention space, in the healthcare space, and we've been, advocating that there needs to be a great deal of caution around physician-assisted suicide and euthanasia and eating disorders. That this is the caution should not be let's wait and see before stopping it. It should be let's wait and see before offering lethal medications to people with eating disorders. And one question that comes up in those organizations is, how do parents feel about this? We don't want to upset parents. We don't want to upset families. So I'm going to start with that question. As parents and families, what are your thoughts on this issue?
I have a lot of thoughts on this issue. First of all, it's terrifying for me that this is a treatment pathway, meaning it legitimizes dying and death in treatable patients. And I think the treatable is really what I want to emphasize here. Eating disorders are treatable. And, just because you try one treatment and it fails the patient doesn't mean that the next one will fail the patient. It means that there's always hope and that we always have to try. And to me, it's very illegitimate to come up with a way to cast our kids to the side because they're quote unquote treatment resistant. Eating disorders are notably hard to treat. Sometimes they're impossible to treat. It doesn't mean you give up on people with eating disorders and you say, okay, well, they're just going to be terminal because X amount of people are going to die of eating disorders. So we're just going to put them in that bucket. So that really angers me, as a parent, that our children are seen as liabilities. And they shouldn't be seen as liabilities. They should be seen as people with potential for recovery with the right treatment in the hands of the right providers. And it scares me that as a field, the eating disorder field didn't come out with this loud voice against terminal anorexia. I would have expected there to be an outcry. And that also makes me angry that it has become something. Yes, there are people who are outraged. There are providers who are horrified. It's not that there aren't. It's just I would have expected more. I would have expected a roaring, overwhelming majority to come out against this, and they haven't. So as a parent, it makes me feel very isolated. As a parent who leads a 9,000 parent strong organization, I really am horrified on behalf of all the families across the world, that, providers aren't taking more of a stand against this. But it really, it really, it makes me sad. It just really makes me sad because I think that, and I think Petra will probably agree with me that, as a parent, even when you know that your child's recovery is unlikely, you're still holding that hope, because we can't give up hope. We can't give up on our children. And it seems like our children are being given up on, and we're powerless to do anything against it. So, from where I'm coming from, it's just, it's unjust. It's unjust that our kids are not given the chance for recovery. They're not given a pathway for recovery. There should always be treatment for people with eating disorders. I don't care how long they've been sick. I don't care how elusive their recovery is. There should be a treatment pathway. It can look different than a treatment pathway for a 15-year-old who just developed anorexia last week. It doesn't have to be the same pathway, but there has to be a pathway that leads toward life and that leads toward recovery. And I feel like this is just going against all of that. So that really, that hopelessness and despair, really despair at the eating disorder, professional community, that they're not with us. That's what really hurts. And again, I want to emphasize there are plenty who are with us. There are plenty who are verbal. There are plenty who are fighting. There really are, but not everyone. So that just makes me really sad and angry, to be honest, sad and angry.
Thank you so much, Judy, for sharing all of that. I think this voice is not heard enough. So I'm really grateful that you've given voice to what I think many parents and families are feeling. Sarah, Petra.
Maybe an additional to Sarah there. I think there's nothing more to say for me, but maybe it makes a big difference to say you are a problem or you have a problem. And I think this is the main point for me in this discussion.
That mistake, it's placing the problem in the individual instead of recognizing that the individual has an illness, and that also there's a whole system of care around it.
Because a human being with an eating disorder is not a problem. She has a problem, but she is not the problem.
Yeah.
But they treat them like they are a problem.
Yeah. Yeah, you can see it in the language as well.
Yeah.
Treatment resistant patient, intractable, all of that. Yeah.
And it really causes me a large amount of concern when we hear language around treatment resistant or inability to access treatment. When we see in our various countries' legislation, in our own country, for example, the right to access treatment that's suitable for the person. And we see through literature internationally individualized treatment. So if one approach isn't working, then try a different one. We also know that what works for somebody who is non-neurodivergent isn't suitable for somebody who's neurodivergent. So automatically you need a different approach. So if we have one treatment that's rolled out for everyone, it's not going to fit a large amount of people. So when we see labels like treatment resistant, it really, really causes me a lot of concern and confusion when we also see in the same instance treatment should be individualized and patient-centered. So those are areas in black and white that we're not seeing followed. So we have treatments available and they're not being offered, or the workforce isn't being trained in them, and it's not available. And we really have no excuse with the amount of ability now to access training or treatment or therapy virtually now. There's really no excuse. And the issues of using terminal for an illness that's not a physical illness is a huge problem. Straight away, that's problematic. And when we see words like palliative being used, how do you define palliative? How do you define terminal in a psychiatric illness? How do you say for certainty that somebody meets that criteria? Because we also are aware as well from a lot of research that the longer somebody has an eating disorder, the greater the rates for recovery. My own journey lasted from age 13 to into my early 40s. I'm 58 now. I know of many other people who have managed to reach full remission or recovery. I know that if I had been told you're going into palliative care, you're terminal, that would have destroyed hope. And that is the other issue. By using those terms, it is taking away hope for people. So I've spoken to so many parents about this and so many carers and so many people who have either lived or living experience of this situation about the effect of these words, and it's soul destroying. We need to see hope promoted instead of being told somebody is hopeless. And we also see the 9 truths of eating disorders. Recovery is possible at all ages, all stages. We see lots of hope promoted, but then we see the words terminal and palliative being used. And another issue that we're seeing as well is when we see specialists using those words, we're seeing those words filter into the general system. So when somebody is in a really, really acute situation, in an emergency situation, notes are looked at and they're told, well, you're terminal, so there's little point in us really doing much. It's taking away hope when hope is always there and should always be there. So that's really something that greatly saddens me. And it also makes me angry, because we know that there are ways that we can keep working with people, we can keep supporting people, we can keep providing love and compassion. So using those words and that terminology is the opposite of doing that. We need to be promoting what people can do, what's available, and what can be gained from life, not removing those options. So those are probably the key points of how it affects me personally and our family from being in that situation, by being told my child was unlikely to survive the weekend. That was 3 years ago. So we need professionals and clinicians to be supporting us and promoting that hope and sitting alongside us and offering alternatives. Something's not working. Why keep doing it?
That's it.
You've got to assess what's happening If it's not working, try a different way, try a different approach. Remain curious and open. Look at other treatments that are available. Keep training, professional development. That is a huge thing. And assessing what you're doing, how you're doing it. And the person, if they're not responding, they're not failing the treatment is failing the person.
Yeah, that's it.
Yeah. Yeah. Thank you, Sarah. I want to draw an underline a lot around some things you've said, and I'm seeing some themes come up in what all of you have shared. That concept of treatment resistance. In the systematic review we did recently, 42% of the cases where people with eating disorders were offered euthanasia and died through euthanasia or assisted suicide, the physicians cited treatment resistance as a reason they were eligible for lethal medications. So I think what you said about it filters the use of those terms. They're lack an empirical basis, and that filters into treatment pathways and clinical pathways. Another thing I think you spoke to, and Judy spoke to some extent, is the power of language to deprive people of hope. And I think you spoke to it a little bit, Sarah, the use of these terms like severe and enduring eating disorder, severe and enduring anorexia. Those are not validated or formal medical diagnoses, and yet they are being used to determine treatment pathways. And then in our study, we found they were used to justify prescribing or administering lethal medications to people with eating disorders. So they have a real impact. On that note, I want to ask you all, when there's this, I've noticed this sort of, I don't know what else to call it, but unethical. But it's a subtle type of unethical, and it's systemic. But this idea of a person with an eating disorder is either being rejected from treatment, or only given one kind of treatment, or not able to access treatment that is effective treatment. So on one hand, they offered that, and then on the other hand, you have the system them blaming the person or offering them a lethal medication as a way of alleviating their suffering, because apparently their suffering is intractable. So there's this, it's not happening in one person, it's systemic. It's, oh, you're not getting better? Okay, then this is the only thing we have for you. Can you speak to that dynamic, and also what it is that families and individuals need that's different right now? So it's really easy to point at the problem. And I think you spoke to some of it, Sarah, but what do individuals and families need right now that's not happening?
I think Sarah spoke to it when she said continuing education. I'm amazed, really, at the fact that most providers only know how to treat using one modality of treatment. In many places across the world, it's outdated. They're treating as if it's 1985. They're parent blaming. They're not using evidence-based treatments. They're just treating randomly, almost whimsically, however they think patients should be treated, without regard for literature, without updating their treatment methods. And I'm always amazed. I used to think that it was because I lived in Israel and we're a small country with socialized medicine. I used to think that that's why my daughter's treatment was so bad. It wasn't all bad, but some of it was really bad. And then the more involved I became in FEAST, and certainly now in my position, really we have parents from over 100 different countries, and it's horrifying to hear of the same systemic failures everywhere. And I think that really the lack of, and I understand that providers are really busy. I do. I mean, so many of them are my friends, and I see what their lives are like, and they do everything. I mean, they're working crazy amounts to try to save lives. They are. And yet, very few of them are learning other modalities of treatment. When you only have one way to treat, and as Sarah said, it's not going to fit everyone, then you're going to fail a huge percent of people, just out the gate. Meaning without even starting treatment, you're ultimately just going to fail because you don't have the treatment that's going to help them. So I think, more evidence-based treatment education the more use of evidence-based treatment. Because when there's an evidence base, you know that it's going to work for someone. It's not going to work for everyone. I mean, even the highest evidence base is really, abysmal, quite honestly. And what also upsets me is that the needle hasn't moved on efficacy rates of treatment in 30 years. And I'm, again, amazed at that the community of professionals are not outraged at this, and frustrated. Meaning, wouldn't you be frustrated if, your patients weren't getting better? Wouldn't you think, okay, well, something has to change because I'm not serving, the full potential of what I could do, and yet nothing seems to change. So I think it really lies in the lack of adaptability. I think I would call it the lack of adaptability to learn new treatments, to change the way that you treat. Because providers who are learning new treatments and who are kind of using them as a combination, in other words, they're not using, things from, that are manualized. They're kind of taking pieces from here and pieces from there, and they're succeeding. Meaning because they're treating the actual person. They're not treating an illness. They're treating a person. And I think Petra kind of alluded to that a little bit too, is that, our kids are people and each one of them is different, and they're not cookie cutters. There's no cookie cutter treatment here. And yet that's what's being used. So, I am very sympathetic to providers. I am. And I know that it's not easy for them either. And with that, I'm still just in awe of the fact that they don't, change. They don't change what they're doing. They don't change how they're doing it. And I think that until they do, we're not going to see progress. I also think part of it is because there's not enough research money, so that treatments can't be developed. New treatments can't be developed because there's no funding for the research. I think sometimes the research is not targeted toward patient care. The dollars that are, or whatever currency it is, that are going into research, the research is a little misguided, away from actually improving outcomes, away from reducing suffering, and towards some academic, whimsical thing that they think is interesting. So I think that's a piece of it too, that the research isn't matching the need out there. But overall, I just think it's amazing to me that it's really a global issue. The countries with the best healthcare systems still have patients who suffer, which doesn't make me feel better, obviously, but it makes me at least feel like if I brought my daughter to a different country for treatment, the outcome could have been the same. Meaning there's no guarantee that had I taken her somewhere, with a much better medical system, that, she would have gotten well, because there are so many people that just are staying sick. So, there has to be almost a revolution in the field, like a revolution toward, okay, this is not acceptable anymore. Too many people are dying. Too many people are being put on this terminal pathway. How can we change? And I've been in this field for over a decade and I haven't seen the revolution. And I'm really waiting for it to happen.
Agreed. And another thing as well, just to sort of in addition to everything that Judy said, is right from the start. The research that we have got there, we have got some really great information which shows what works well and what doesn't. And we also have information that really could make a difference right from the start. So we're seeing long journeys with people that have been going through years of having an eating disorder, and all of those co-occurring conditions that go alongside anxiety, depression, OCD, all of the other things. Right at the start, people are being missed. And we have a really fat-phobic culture which prevents people from being able to access treatment when they need it, because we have that research there, we have statistics there to show that there is a real misconception about how people should look if they have an eating disorder, and it's very much guided by weight, size, and shape. So people are unable to access treatment if they're considered to be at a normal or healthy weight, when we know that less than 6% of people are clinically diagnosed as being underweight. So that leaves 94% plus who aren't, and then they aren't able to access treatment. So then we see long-standing eating disorders because they are not able to access treatment. So we need to be looking at our system right from the start and training our medical students, our nursing students to be aware of those core competencies needed to appropriately support people. We also need to be looking at assessing how well things are working. That's another critical thing. We also need to be assessing what a long-standing eating disorder is. We're seeing kids being diagnosed that are 13, 14, 15, 16, 17 years old, being classified as severe and enduring. I will use the old term. How can that be when we see it's not an official diagnosis? And we see, even if it was, a proposal of a much older age category for that. How can you classify a child as having a long-standing eating disorder when they haven't even accessed treatment to be able to support them and their family through it? So we need to be looking right at the start what's happening. And we're supporting people into their 40s, their 50s, and they've never accessed appropriate treatment. They've never accessed support. So we need to be looking at, as Judy says, a complete revolution in how we're approaching this.
Thank you, Sarah. Yeah, I the term severe and enduring eating disorder is an interesting one. It's defined in about 10 different ways in the research literature. Some, and it could be a person with an eating disorder for more than 3 years, more than 5 years, more than 7 years. But I have to say, I rarely meet a person in their 20s or 30s that's had an eating disorder for less than 3 years. It's I wouldn't even say it's the nature of the condition. It's the nature of the condition in this particular healthcare system. So meaning that, the condition is prolonged and protracted because people aren't able to get access to care, like you said, so or effective care. I want to ask you, Petra, a question, and then we'll move to questions. But I want to make sure we cover this because I'm so aware that I really feel like families have been left out of this conversation. In fact, I was saying to some of you, I know of families that are not only being left out, but pushed out of the conversation. So, when they try to get guardianship or conservatorship over their kids, because they're dangerous, if they're dangerously sick, having people fight them on that. So I wonder, one thing I want to bring families into this conversation, but I'm thinking about the emotional pain of that families are carrying in those helpless, desperate periods. And there are those. I know in my own family, there were periods where, a therapist said, I fired me, I'm not going to see that patient anymore. And the family, my mom's like, what do you mean you fired her? How you're a therapist. How you can't fire your patient? Or we didn't have insurance anymore. And so there's nothing to do. And I'm getting sicker and sicker. So I want to ask you about the emotional support that families need in those moments, because I don't feel like the field is having a conversation about that at this moment. There's so much focus on, quote, terminal anorexia that people are forgetting that there's an entire family that is being affected in these moments.
I think the most factors giving them a space to speak about their feelings, their emotions, because they heard a lot of facts, and that's what Sarah and also Judy talk about, the fact-based thinking and operating in our world. But what they need is a space to speak about their feelings, their emotions. And then for me, it's very important to use words which are based on love, on empathy, and anything, because the information they get from the doctors, but they don't need information. They need a view of a perspective. It's not hopeless. You may find a way, and as Sarah told, it's there are so many ways, and I learned if this way is not the right one, take the other one. And this is what I like to give the people that they talking with me. And what I felt when our daughter was in hospital in the intensive care, even the senior consultant, when he saw our daughter, he was really overwhelmed. He was a doctor for 10 years in this intensive care, but he was overwhelmed by the tragedy. And he had never such a case in his medical career since this time. And he had to take information from colleagues. He didn't know what to do. Just he tried to save her life, nothing more. And but I felt in peace with him because he talked very often to me. He told me, I have never seen this. This is a tragedy for me, and so on. And that's what I also felt. And so we have a good situation to talk about because he is not on a higher level and he didn't talk about facts. He just talked about his emotions. And I felt he will do the best he can ever do. I think this is very important to also for a doctor to talk about. I don't know what happened. I don't know what to do. Maybe we can find another way for treatment. Maybe we can find another solution. Not put you on this higher level and talk from the top to the person. They are really down. They don't need talking from the top. They need a pushing up.
I really relate to that a lot. My daughter's therapist at the end of her life was just amazing. And she couldn't save my daughter, but she was there for her. And that made me feel like we were supported. Even though we weren't necessarily involved in her treatment because she was 27, I felt like somebody was taking some of the burden off of us and helping us carry it. And that was so significant to me because the burden was so heavy. And I'm always amazed at how little care there can be in patient care. It's almost an oxymoron sometimes or a misnomer. And that to me is one of the biggest tragedies. And, when somebody relates to you as a human, I speak to a lot of providers. I present to them on what parents need, what they need to know, what they need from you. And one of the most important things is connection. Make eye contact, smile at them, make them feel like you're with them, make them feel like you care. When somebody's treating your child who cares, even as Petra said, if they don't have the answers, if you know that they're going to go out there and try their best, sometimes that's the most we can ask for in these circumstances. We have to be realistic, but that's very meaningful to parents. So I think for parents to feel supported, they have to feel like the person who's treating their child cares. And there's so many ways, it could be nonverbal, but there's so many ways to communicate that you care. And I think that's what made me feel more supported. But also psychoeducation, meaning it was important for me to understand, what I needed to do, how I could help my daughter, because so many times we're left out of the conversation and nobody gives us any information or any instruction or any guidance. And we're left floundering. And a lot of caring for someone with an eating disorder is also very counterintuitive. And that's what's so hard is you're navigating these challenges. And if you don't have, professional support. I mean, parent support, peer support, obviously I believe in it. It saves lives. I mean, I have no doubt that what we do at Feast saves lives. And with that, people treating our kids have to be supporting us as well. It has to come from all sides. And they have to really teach us, how to care for our children, empower us. That empowerment is really critical, and parents aren't getting it from their providers. So, sorry, I didn't mean to hijack the conversation, but, I just wanted to add on to what Petra said, because I really felt that. Like, yeah, I really felt like when someone's caring for your child, especially when they're very sick, and you can see in their eyes that they really do care, even if you're not positive that they're competent. But if you know that they're going to try their very best as a parent, that really, to me, is so significant and so meaningful. And I'll take that almost any day over somebody who's arrogant and competent. And as Petra said, speaking from up here when you need someone to be, actually with you and lifting you up. So I really related to that.
Thank you. Thank you, Judy. Yeah, and I think part of what is missed often is that parents are really, this is an overused cliche, but they're on the front lines of the work of recovery. There is so much friction that is happening in the home, because it's, the child goes, or the person goes to therapy or nutrition and they're told what to do, but then when you go home, that's where the work actually happens. And guess who gets assaulted with the, I can't believe you're making me eat this, or who are you to tell me, so all of that. So I think really having that deep respect for parents and recognizing that they are probably seeing a whole lot more of their of what's happening in that work than you are, and are going to be there long after you are as well. It's I have to, my mom in those moments was there with me, and as much as I demonized her, she's the one who's still there with me today, not the therapists or the doctors at those moments. So I think what you shared was really important. I want to go to a question from the audience, and just those who are here with us live, if you throw any questions into the chat, I can try to direct them to our panelists. And I think it's a good segue from where we were just speaking, but the question is, what do you do when your child can't access treatment? Maybe they're refused from treatment because they've accessed the service too often. And I know your organizations are really at the heart of this work. I'm sure you hear from parents all the time, but when a parent is in that moment and their kid has tried to access treatment and they're being told, no, you've gotten enough treatment, you're on a waiting list for 4 months, we don't take your insurance, how do you navigate that?
I think it's quite important to first of all, really identify the country, because there are so many different systems. We have public systems in some of our countries and private systems in others, and insurance-led systems. So that's one important thing. It depends what country.
I don't have a country for this question, but maybe, I don't know if you want to speak broadly, and maybe you could speak just, and Judy, I guess you work internationally.
Yeah, broadly, really, the first port of call for us would be to your GP. This is where we start to come across a few difficulties, though, because we need GPs who are understanding and who are aware and who have additional knowledge and understanding of eating disorders. So really the first port of call is to contact your GP and ask if they have knowledge and awareness of eating disorders and up-to-date knowledge and awareness. And if they're not able to help, ask them to refer you to somebody who does. That's a really important one. Or if they're open to receiving whatever training is available in the country. We have free GP training available in New Zealand. It's online, 4 hours, self-paced, so it's very accessible. So that's one thing to be aware of. But if somebody is unable to access services, going back to your doctor and asking for their support is a really important one. They're like the hub of support to us here, and it would be fairly similar in Australia.
I might, the only thing that I would add, unfortunately, is that parents really have to step in and step up, and there's no choice. And, that's why I think we need peer-led organizations, to be able to guide parents and to say, okay, this is what you need, including medical monitoring. This is what you need done. Because so many times, as Sarah said, if a GP is not specialized, they don't know how to test or what to test or to evaluate whether your person is stable. And parents a lot of times really have to walk in with a list and say, okay, these are the tests you need to do. This is where the numbers need to be. We need to basically take on the role of treatment providers. Partly because, as Chelsea, you said, a lot of the eating disorder treatment is done in the home. And just partly because there's so many gaps, and we have to fill them, and it is so unfair. I mean, I'll say that outright. It is so unfair to put that on us, but the reality is that if we don't do it, nobody will. So, I tell parents, you have to just be educated on all areas of eating disorders. And, in the case that was presented, obviously it's somebody who's been through the system multiple times. So we're not talking about getting started and how to feed and all that. We're talking about more complex than that. And, there are ways that parents can learn about what to do. And as parents, all I can say is we just do our best. I mean, but it's a great sacrifice, because sometimes you have to give up your job. Sometimes you have to only work from home because you can't leave someone unsupervised. They could be a danger to themselves. They won't eat, they won't comply with whatever rules you need them to comply with. So, the sacrifice that parents have to make is just, it's unfathomable. And sometimes when I speak to parents, I hear myself and I know what I'm asking them to do. And I'm crying on the inside because I know how hard it is. I'm saying it matter of factly, right? Like, this is a list of things that you need to do, but I know that it's insurmountable. It's challenging them beyond their wildest limits. And, that's a really hard thing, but it's necessary. It's necessary for someone to tell them this is what you need to do. And I know it's going to be hard, but you have to do it. So I think that's where we come in as people who lead peer support organizations, in giving parents not only the information and the education, but the empowerment, because you have to feel like you can do this. If you feel like you're going to fail, you're going to fail. If you feel like you're going to succeed, you have half a chance of succeeding. So it's not just the information, it's the empowerment. It's building parents up to believe that they can do the really, really, really hard things, and validating that it's hard, meaning don't sugarcoat it. Parents are very smart, but you have to validate that it's going to be really hard and that you're going to do it with them. But I mean, we walk alongside parents in these situations all the time where there's no treatment team. There's no treatment, there's no anything. There's just one parent, two parents, sometimes an extended family, but that's it. And, they have to know what to do and how to do it. And, it's heartbreaking. It's really, really heartbreaking.
Yeah,
And
thank you.
sometimes it's very important just to follow your heart and not your head. Yeah, I think this is one experience I made accompanying my daughter all the time, because often I ask her, what do you wish? And most of the time, she don't want to talk to a doctor or to a therapist. She just want to feel love and heart. And I think this is one of the main points. And this is so why the work or to support parents is so important for us, because they can give their children what they really need, not what others think they need.
Mm. Yeah. I'm so glad you've both spoken to this, and I just want to emphasize the role of families and peer support. I've reached out to I have parents reach out to me sometimes. I'm like, oh, of all people, but I get outreach, and one of the things I noticed one of the first questions I ask is, are you getting support for you? Do you have people that are supporting? Are you seeing a therapist? Do you have friends who are holding this with you? And more often than not, they don't. They don't have people supporting them. They are so focused on supporting their children at that moment, and that they are flailing. So I've referred to Judy. I've referred to 30 Days of Feast, which is an exceptional. I've done that program myself just to see what it is I'm referring to. So it's fantastic for education, but also link up with other parents, link up with these organizations, because just having that moral support from and community from others makes a huge difference, and you need it. I think I'm watching our chat to see if we have any other questions. This may end up being our last one, but I want to. It's a fairly personal one, and you don't have to go too broad here. But I'm wondering, for each of you as parents, what is something that you wish you knew earlier? So, thinking about a parent who might be watching this right now, who isn't this far along in their journey, but what is something that you wish you had known a lot sooner?
So I think I wish I would have known how long the journey would be. Nobody tells you. Also, we're used to, medicine where, my daughter had appendicitis. So she went to the hospital, she had her appendix removed, she had a week of recovery, and then she was fine. So the expectation is that you send your child for treatment and they will be healed. And nobody tells you that it doesn't work that way. And so I wish I would have known how long the path would be. I wish I would have known how involved I would have to be. Because again, if your child had a disease like cancer, as a parent, you wouldn't have to be involved in their treatment. You leave it to the doctors, and you're there for moral support and for the love and for the care. But here we have to be part of the treatment. And nobody tells us that either. So I really wish that I would have known. I also wish that I would have known about family-based treatment earlier, because we lost a lot of time and ground with dietitians who were just foolish and who allowed my daughter to lose a lot of weight. And I wish I would have had education. Our Feast 30 Days program that you referenced, I wish I'd had that. I wish I'd understood what eating disorders are and how they're treated and what good treatment looks like. And I wish I had understood the neurobiology to understand, that I didn't cause it, that it's something that's in her brain, it's genetic, it's metabolic. Because you lose so much time as a parent feeling guilty and feeling blamed. And I wish I didn't have to, catch up with that as well. So I really wish I would have known that. I also wish somebody would have educated me about suicidality, because no one did. And, all of a sudden we got a call one day from where my daughter was being treated that we had to come and get her because she was suicidal. And it came out of left field. She never had any type of suicidality before. And it was years in, because that's how it happens usually. The comorbidity shows up, when you're already kind of deep into it. And I already thought I'd mastered eating disorders, whatever that meant. She was still sick, but I felt like I understood eating disorders. I knew how to treat them. I was comfortable in my role. And then all of a sudden, suicidality came and it knocked me down because I didn't know anything about suicidality. I didn't know how to evaluate risk. I didn't know where on that spectrum she was. I didn't know whether we talk about it, whether we don't talk about it, whether if we talk about it, it causes action. I didn't know what to look for in terms of signs. I didn't have language to use with her. And, I had to educate myself. I mean, I taught myself DBT, and I don't know what I would have done if I didn't speak English and if I didn't have these YouTube videos, which really saved my sanity because it taught me, okay, how do we deal with suicidality in a child? But the suicidality was there, and no one in her treatment team thought, to educate us. So I really wish that I had known that suicidality was a serious option in terms of a symptom that would show up, so that I could have learned it ahead of the curve and not gotten behind the curve, because that was really vital. So, I have a lot of wishes, and I wish I had done things differently. And I don't have a crystal ball. I can't say that if I had done things differently, my daughter would be alive. I have no idea. I mean, eating disorder statistics, the mortality rates are very high, and there's no guarantee that she would have survived. But I feel like had we known in the beginning, had we been better educated and better informed and known more about good treatment and evidence-based and all that, we would have made different decisions and it could have had an impact. And I try not to feel guilty about that because, you know, I still think I'm a good mother. I still think I did what any mother would do. I spent thousands of hours online researching and trying to find, you know, the best treatment for her. And I didn't know what I didn't know, meaning I didn't know that the treatment that we found wasn't good. I didn't know that it didn't have an evidence base. How would I know that? So I feel like just, you know, the education that needs to be provided for parents is vital and it will save lives. And I'm just sorry that I didn't have that education starting out.
Thank you, Judy. And I am so grateful that you were doing the work that you're doing to provide that education, because that it's out there now. You know, those resources are out there. And I'm glad you underlined the point about suicidality and eating disorders. It's the second leading cause of death in eating disorders. And it breaks my heart that we now have a medicalized suicide option in some treatment systems. I can't wrap my head around how we know we have the research to show malnutrition leads to depressive thinking and suicidal ideation. And yet somehow we're saying, oh, but it's not suicide if it's wrapped in medical clothing. So just sorry, I didn't mean to interject there, but I really want to draw an underline there. I think it's an important point. Sarah Petra.
Yeah, I wished I know anything Judy said. And I also wish to know that I have to help myself. We already talked about. And I wished I had known that most of the the things what pushed my daughter are in her subconscious. I thought it's in her head, and if we do this technique and we use this technique, then maybe in few weeks, maybe in some months, it will work. But it's in her subconscious. And also, I'm a yoga teacher, and I wondered when we practice yoga, she felt well. And I wonder if why there is no yoga in the clinics. And I wonder that there were no information about practicing yoga or breath work. It's so important. And now, so this is my work. I will bring this practice to parents, and I also will bring this practice to people who are suffering with an eating disorder, because our body expresses our feelings, our emotions. And it's not so difficult to work with these expressions, but it's difficult to work just with your brain. This is not working because first you have your emotions and then the brain comes afterwards and said, oh, what happened? But then it's done. And so I wished I knew this in the time my daughter was so ill.
Just say we are building that evidence base on yoga.
Yes.
There are now dozens of studies showing that yoga can be effective in treatment and in prevention. So I hope we see that become a more integrated part of care. Sarah, you want to round us off? Final last words. What do you wish you had known?
Well, Petra and Judy have covered so much of all of those wishes. My basic wish there is all of those, and to keep it simple and to trust your gut.
Yeah.
You know your child, you know what works for them and what doesn't. We have so much information now that talks about individualized care, neurodivergent populations, etc., but that all means the same thing, individualized. You know your child, you know the person, you know how they respond to things, and keeping it simple. And I wish that I had known, even when I had found out about evidence-based treatment, FBT, etc., that it wasn't necessarily followed. It was quite often simply a name, and it was still completely down to the person's opinion. And to not allow weights and targets and numbers to be such a focus, and to remove that pressure away from my child and so many others that I see that do not react well to having those pressures. And keeping it simple, knowing that to trust your instinct are the really important things. And I wish I'd known that there was no clear pathway. And right from the start, not to wait and see as I'd been told to do. To wait and see is losing really, really critical time that we could have been supporting and working together much better. So those are my only wishes, that really support those that both Petra and Judy have already talked about a great deal. But knowing that to trust your instincts and to keep things simple are two really important things, and to put your all in right from the start and be aware that you do have to make time. It's not something that is your child's fault, and to know that your child is still there, that the condition is not your child, it's the result of malnutrition. So if you can get your head around the basics, then you can really start to separate things, and to know that your child's there so you can give them your love and support.
Yeah. Thank you. I feel like we need to write all of those up. Those were excellent. And I want to thank you all so much for spending this time with us today. We will, this is recorded, so we will get the recording up on YouTube just as soon as possible. I want to remind you, there have been, I think this is the 5th in a series of conversations that we've been having, all of which are up on a YouTube playlist, so you can watch previous conversations. And then last thing, we've got another event coming up on September 21st. And that is we've got Dr. Angela Garda, Dr. Mark Comrade, Dr. Annette Hansen, oh my gosh, who's that? And Dr. Claude Regnard, who physicians from different areas of specialty, who are going to be talking about the real ethical conundrum of assisted suicide and euthanasia in eating disorders. They are wicked intelligent people, and I'm personally, the nerd part of me is just so excited to hear that conversation. So I want to invite you to that, and also invite you to visit each of the websites of these 3 incredible speakers I've had with me today, and to add them to your referral toolkit. I use Feast often, and I will be using Hungry Hearts and EDCS a whole lot more often now that I know that you're there. But do know that these organizations are there in the world and doing amazing support for families and caregivers. So thank you all. Thanks for being with us this morning or evening.
Thank you.
Thank you so much.